So again, thanks to IMM for this PG Masterclass. And as I commence, I'm Dr. Sumit Rai, Professor and Head of Department of Clinical Microbiology from IAMS Mangalgiri in Andhra Pradesh. So, like I said, we have had a masterclass on resistance in gram-positive cocci on 26th of April, for which this link is given over here. For those who have not been able to see this video, can go ahead over there. We have discussed more details about the gram-positives, specifically on Staphylococcus aureus, on MRSA, on Visa, VRSH, Visa. And over there, I think we realized that somewhere we didn't do enough justice for vancomycin-resistant enterococcus, which even though may not be a very huge topic, but yes, it does carry a lot of weightage as of today. So we're going to just have a brief layout for this masterclass as the introduction and what are the clinical presentations, brief epidemiology of VRE, the resistance mechanisms, the diagnostics, and the methods for detection, treatment options, and one small slide on what is vancomycin-dependent enterococcus. So, why we are talking about VRE specifically is that the treatment because of VRE is uh, almost 10 times more expensive than the normal enterococcal infections, and it's definitely associated with much higher morbidity and mortality. So, just giving you a brief introduction, starting with enterococcus only, that it is a facultatively anaerobic gram-positive cocci arranged in chains. It's slightly oval, and the chain forms are best appreciated in the liquid cultures. They grow at 6.5% sodium chloride salt, and they are salt loving, and they are can grow at a higher pH of 9.6 alkaline pH. The temperature ranges is also quite variable from 10 degrees to 45 degrees, and classically they are identified by the heat resistance tests, which showcases its ability to withstand heat up to 60 degrees temperature. And they form the normal colonic flora, almost 10 per 8 colony forming units per gram of stool. That's not a very high volume considering the number of bacteroids we have in the stool samples. They also form the normal flora of the oropharyngeal and the vaginal secretions. And they're also isolated from soil, water, food, and domestic and poultry and draught animals also. So those who are exposed to animals or have poultry and all those, so they are likely to be infected with enterococcus that is also vancomycin resistant. So it is not as intrinsically virulent as Staphylococcus aureus or beta-hemolytic streptococcus. And the interpretation, therefore, that's the interpretation is very, very difficult. We must know that whether it is really a true pathogen or not. So, uh, just a minute. So, yes. So, continuing with the introduction to VRE, or vancomycin resistant enterococcus, it's got a lot of intrinsic resistances and acquired resistances as well. Some few myths and facts about MRSA is that, VRE is that unlike MRSA, most VRE isolates are not caused by indigenous flora, but by the acquired strains. So usually they are hospital acquired, or they might be acquired through the animal sources, through poultry or through food. The long-term care facility patients, they are especially the reservoir in the hospital because they've been on long-term cephalosporins, which often select out the VRE isolates. Enterococcus faecium is less pathogenic than Enterococcus faecalis, and in fact, many VRE isolates they resolve without any active antimicrobial therapy also. So we have to be very, very careful whether we really need to treat a VRE isolate or not. We have to establish the true pathogenicity of that particular isolate with the patient. If it's not there, then it must be a commensal or a transient flora. It's vancomycin is bactericidal for all gram positives except for enterococcus. So it's cidal for staph, but it's uh, static for enterococcus. And enterococcus faecalis is typically 10 to 100 times less susceptible to penicillin than are the most streptococci, while enterococcus faecium is at least 4 to 16 times less susceptible than enterococcus faecalis. So faecium may be the culprit at times. Even though it appears to be less pathogenic, but when the resistance is there, it's quite dangerous. And if it is a ampicillin resistant enterococcus faecium isolate, it's usually a hospital strain. So in case you have an outbreak of ampicillin resistant enterococcus faecium, then you have to search for the source to be somewhere in the hospital only. So this is a very interesting table for which the reference I've given over here. What are the intrinsic resistances and what are the acquired resistances? The acquired resistances and the HLAR also we have discussed in the previous presentation that was on 26th of April. So if you want to refer to what is HLAR, so in Enterococci, you can refer to that particular presentation. Now, what are the clinical manifestations? Infected endocarditis is one of the most fatal cases, one of the most dangerous ones to treat when it comes to infections caused by VRE. Bacteremias, hepatobiliary sepsis, because that's often the source, the hepatobiliary duct, the gastrointestinal tract is a retrograde transmission from the GI tract into the blood, causing bacteremia. And for which there we just need to have standard diagnostic protocols, but because this is not a very fastidious organism, we don't need to have special media for that. We just have to do a culture immediately with immediate incubation in the emergency, for which we already have a 24/7 clinical microbiology lab. We have a three-tier reporting process where the blood culture, the moment flashes positive, the gram stain is made, and what we see is a slightly over GPCs. We immediately give a call that gram-positive cocci in chains can be seen. Probably it could be enterococcus, and we from the broth only we'll put up the bilasculine agar, that's the BEA, along with ATCC 29212 enterococcus. There are no rapid AST breakpoints as of today, but we do put up the discs from positive broth and interpret after 12 hours. We won't say it's susceptible or resistant, but I just have a rough, outline whether what to expect in the final AST. And the third one is the standard AST. We put up a GP628 cards and also our curvivore distribution manual AST panels as per the CLSI protocols. Then there are other infections like cholangitis, peritonitis, intra-abdominal pelvic infections, complicated intra-abdominal infections, catheter-associated UTIs. Enterococcus is one of the commonest causes of enterococcal bacterium, enterococcal cautis. And but at the same time, enterococcal bacteremia due to UTI is not very common. So urosepsis you won't very see commonly with enterococcus. Skin and soft tissue infections and the diabetic foot infections also are caused by VRE isolates. And in cases, iatrogenic cases might happen in neurosurgery where it might cause CNS, meningitis in the CNS. So this is just an outline as to show you what I just said just now. This I think I might have shared previously in some of the presentations, how we are treating our positive broths or the positive blood cultures the moment we get it positive from the automated machine. So in this case, I'm going to highlight GPC in chains over here. The moment you get GPC in chains, we immediately put up a bilascular agar along with ATC 29212 and a direct AST as per the CLSI protocol. Same gauge of needle, same 4 drops we'll put up, and we'll put up penicillin, Genta 120, vancomycin, teicoplanin, chloramphenicol, erythromycin, and doxycycline. So this is but we don't interpret it. It's just for our own observation. It's because they don't have any breakpoints from the direct AST from the broth as in CLSI as of today. They are only for the Enterobacterales and Acinetobacter and Pseudomonas. So when it comes to the epidemiology and presentation, uh, India has often been blamed for the dissemination of the NDM. But the fact is, NDM was only discovered in India. It was not generated in India. Similarly, the enterococcus infection, the dissemination of VRE started from the US. So most of these MDRO cases have been started from the West only because of the abuse of antimicrobials. And what the literature cites is that there have been two separate waves of the dissemination of VRE all over the world. The first wave began in 1980s in the US that was associated with the introduction of the third generation cephalosporins, which selected out vancomycin resistant enterococcus and ampicillin resistant enterococcus faecalis also. In the second wave, mainly the VRE faecium was there. Again, that was spread from the US. And in the Europe, there was increased prevalence of vancomycin resistant enterococcal in the hospitalized patients. In Australia, almost very high percentage of enterococcus faecium are vancomycin resistant. And the most common clonal complex that is prevalent all over the world is this clonal complex 17. That is the significant burden of hospital-acquired infections, and it's highly prevalent in the gut microbiome of wild and domesticated animals. And therefore, there is a strong evidence of a zoonotic transfer also in cases of vancomycin-resistant enterococcus. So again, it can be one of the poster boys for our One Health program other than Salmonella typhi also. So it does have a strong association with the animals, and therefore there is zoonotic transfers there. And these tonal cluster 17 strains, we have had outbreaks in Europe, Asia, South America, and Australia. And even fresh food has been found to be a significant reservoir for these VRE isolates. And despite there's a lot of community spread, but still community-acquired infections by CC17 strains are uncommon. It seems that despite colonization, the infection will happen only once there's a lot of stress on the patient on antimicrobials, and that's why the long-term care facility patients on long-term antimicrobials like vancomycin themselves are prone towards developing infections caused by VRE. So the outbreaks are typically of long duration. It's not very easy to suppress or control a VRE outbreak. So normally they'll go as long as 8 to 10 months or maybe 11 months at times. And typically the vancomycin-resistant enterococcus faecium in the bloodstream of hospitalized patient is typically preceded by antibiotic exposure. So there are typically some antibiotics which are involved which incite or induce the resistance in the enterococcus faecium isolates. And there have been control measures have to be taken, like isolation rooms, contact precautions, and dedicated room cleaning. And because VRE infection is a menace, because it creates a lot of excess mortality, duration of hospital admission gets increased, there's increased treatment costs, especially when it's a bloodstream infection, which warrants almost 6 to 8 weeks of therapy, almost 2 months of admission. And of course, to top of it, it might be a linezolid resistant VRE, and for which we have isolated, we have seen cases also of LR-VRE cases also, where the sole option of giving the linezolid is also gone. So if you have to control and monitor the hospital, the VRE isolate the outbreaks in the hospital settings, we have to do surveillance for colonization and the indexing of the cases, identification of the colonized and infected patients, isolation or cohorting of the colonized patients, strict use of gloves and gowns by people coming into contact with the VRE patients. You have to have dedicated equipments and instruments like the stethoscopes and BP cuffs, thorough room cleaning, that's terminal disinfection after the patient gets discharged or patient leaves the room, and limit the use of vancomycin in the hospitals. And that's another reason why to shift from vancomycin to teicoplanin when it comes to the choice of glycopeptides. So the risk factors which are involved for VRE infections include that, yes, definitely if it is enterococcus faecium, it is more prone to acquire vancomycin resistance. Long-term hospitalization, especially in the renal units, neutropenic patients, patients with febrile neutropenia, with hematopoietic malignancies, instrumentations, catheterization, long-term indwelling devices, comorbid factors like solid organ transplants, pre-existing heart conditions, long-term treatment with cephalosporins, especially ticarcil and clavulanic acid. Now, this is one antibiotic that has been specifically mentioned in the various studies as one of the selective agents to create, to cause vancomycin-resistant resistance in enterococcus, uh, even more common than vancomycin per se. Then typically antimicrobials with anti-anaerobic cover like piperacillin, tazobactam, meropenem, and metronidazole on long term are also likely to select out vancomycin-resistant enterococcus infections. Also, oral administration of glycopeptides to humans or animals or poultry also is a risk factor for VRE infections. And of course, there's person-to-person contact. There are contact precautions you have to take, and VRE advisory has been issued by the HICPAC of the Center for Disease Control. So if we talk about how does the actually the cell wall is made up, because this is a cell wall active agent, vancomycin is a cell wall active agent. So what happens over here is that the precursor, because the cell wall formation of cell wall is a pretty complicated process. So there is a monomer, that's a single peptide unit of L-alanine. That's the LIVO isomer of the amino acid alanine. So there's a racemase enzyme that converts the levoalanine into a dextroalanine. So that's the isomer. And then there's a ligase enzyme, that's a DDL ligase enzyme that combines two peptides of two amino acids of D-alanine to form a dimer like this. And then the MURA F enzymatically causes the synthesis of the pentapeptide by the combination of this dipeptide and this UDP tripeptide. So this forms a UDP pentapeptide over here, of which this is the C terminus. This D-alanine is the C terminus. And then this this pentapeptide, this UDP pentapeptide transmigrates into through the membrane, and then it reaches the periplasmic area, and then that's a place where it gets acted upon by the trans glycosylase and the transpeptidase and all the enzymes to create the cell wall. So this is the one this is the actual process for the precursors are formed inside the cytoplasm, transmigrate through the membrane, and then they are made into the cell wall outside. And this is where the vancomycin acts, because it does not get inside the membrane. Outside only it captures over here like this. So this is dimer. This is the C terminus of the pentapeptide, and this is where the glycopeptide will act on it. So when it comes to the resistance mechanisms, now there are numerous resistance mechanisms which are primarily encoded by the VAN gene, or the vancomycin resistance gene, or the VAN gene. The VAN gene encodes alteration of the glycopeptide binding site, which I just mentioned over here, the C terminus. That is the glycopeptide binding site changes from the D-alanine to either D-alanine D-lactase or D-alanine D-serine. So that's the change that happens. From a dimer of D-ala, it changes to D-ala D-lactate or D-ala D-serine. So both of these D-ala D-lactate and D-ala D-serine have got poor binding to the glycopeptides. So there are different types of VAN genes which make the resistance also different types. The commonest one that we'll talk about, and among those five also VAN A, VAN B are the most common. So we have got typically VAN A, VAN B, VAN C, VAN D, and VAN E. And then numerous others which are present in the operon, but I'm not going to explain in details, pretty complicated. VAN G, VAN L, and all these are present everywhere, but which is not been discussed over here. And I'll just cite the reference for those who want to go into that. They can look into the reference over here. So the features of the various vancomycin genes are you can classify them on the basis of the target modification. Like for example, the normal site is the D-ala. So when the D-ala gets changed from D-alanine to D-lactate, D-lact. So this is normally created by VAN A, VAN B, VAN D, and the VAN M genes. When there is a synthesis of D-ala and D-serine, that is caused by VAN C, VAN E, VAN G, and VAN L and VAN N genes. Then if we classify the VAN genes on the basis of their location, so the location is typically chromosomal for the VAN C, D, and E, plasmid for the VAN N, and it could be either plasmid or the chromosome for the VAN A and VAN B, because normally for the VAN A, it is commonly plasmid, and VAN B, it is usually chromosomal, but rarely it can be seen on plasmid. So there are some conflicting things about the transmissibility of the VAN B gene. So the classification based on the gene expression, can be inducible. We have talked about inducibility in the gram negatives. There's inducibility in gram positive also. So the VAN A and the VAN B gene, they are the inducible genes. So in the presence of the antibiotic, they will get induced, and they will create that altered site of D-ala to D-ala D-lactate. So VAN A and VAN B, and in case of VAN B, the induction is caused only by the vancomycin. And the constitutive, that is the natural or the intrinsic expression, is caused by VAN C, VAN D, and VAN N. So this table, it summarizes the different prominent vancomycin resistance genes. So if we go specifically, this is the table that will help us remember also. If you see VAN A, the VAN A expression of the VAN A gene, that will create resistance to both vancomycin and teicoplanin. So as you can see, vancomycin MIC are typically 64 to more than 1000, creating resistance. Teicoplanin is also resistant. Both are resistant. The level of resistance is very, very high. It's most commonly found in Enterococcus faecium, most commonly, followed by Enterococcus faecalis and Enterococcus durans also. There's a VAN A clutter is there, which is an acquired determinant gene, and it is transferable through conjugation, and it's present on the transposon of a plasmid. So I think transposon number is 1546, TN 1546. That is that's got high transmissibility also. And the target modification, like I said, it's from D-ala to D-ala D-lactate. and the induction is typically caused by cephalosporins also. In the vancomycin B, the VAN B resistance mechanism, we'll see that there is high level resistance in case of vancomycin, but teicoplanin is susceptible. So this level resistance is moderate. Again, I would say that why we need to shift from vancomycin to teicoplanin is that despite the presence of VAN B mutation, we can give patient teicoplanin. The level of resistance is moderate and is more commonly seen in Enterococcus faecalis rather than in Faecium. So it's more in faecalis than in Faecium. If the Van B cluster that is harboring this entire operon is also acquired, it's non-transferable, chromosomally enclosed. So this is slightly debatable whether the Van B gene is transferable or not transferable. Some literature says it's transferable, some say it's non-transferable. So the target modification is again same like that, D-alanine to D-lactate. And in this case, the induction is caused by vancomycin, but not teicoplanin. The third one is very interesting, that is VAN-C, creating a low-level resistance. That's the intrinsic resistance that is commonly seen in the motile strains of Enterococcus, which are Enterococcus gallinarum and Enterococcus calciiflavus. In this case, you'll see vancomycin MIC is moderate resistance from 2 to 32, but the teicoplanin is pretty susceptible. And the genetic determinant is VAN C1 and VAN C2 cluster. It is an intrinsic resistance and it's non-transferable at its presence on the chromosome. And in this case, the mutation is changed from D-alanine to D-serine. And like I said, it's a constitutive expression of the. So it's an intrinsic resistance mechanism. So if you see the intrinsic resistance tables also in your CLSI M100, the appendix B, you'll see over there that this typical resistance is there for vancomycin susceptible, resistant, but teicoplanin susceptible, and it's intrinsically present in Enterococcus gallinarum and Enterococcus calciiflavus. So again, this is the same extrapolation of the same table only. Try to make it more simplified. Just to tell you again, just to revise that VAN A means high level resistance to both of them. VAN B means high level resistance to vancomycin and susceptibility to teicoplanin. VAN C means low level or moderate resistance to vancomycin, whereas susceptibility to the teicoplanin. And again, the usual binding sites of vancomycin is normally D-alanine, which makes the vancomycin MIC susceptible at less than 2. Low-grade glycopeptide resistance enzymes is glycopeptide resistance is D-alanine, D-serine, where the vancomycin MICs are 4 to 32. And high-level GRE is D-alanine, D-lactate, again vancomycin MICs are more than 64. So these are references I have already cited. For those who are interested, you can go through these references also. So as you can see that the glycopeptide is not binding to any of the enzymes. It is binding to the target site. So the target site, this target site is already gone. This is the target site, the C terminus, it is gone. This is mutated now. Now the vancomycin won't bind over here. So it is a target site mutation. Just so you can remember about the MEK gene. So just like that only, the beta-lactam cannot bind to the altered target site. Similarly, the target site over here is altered. So the glycopeptide cannot bind over here. So this is an interesting case that we found interesting case that we reported, we published also vancomycin, linezolid resistant Enterococcus faecium, that was also VRE isolate, and we had published it over here. Again, especially if we talk about the vancomycin A resistance, it possesses inducible high-level resistance to vancomycin with MIC in very, very high ranges, both for vancomycin and for teicoplanin. And in this case, the resistance is normally induced by glycopeptides, vancomycin, teicoplanin, and also those drugs which are normally given in the poultry, like avoparacin and risocetin. All these are drugs which are given in the poultry and in the animal feed. Also, it is inducible by non-glycopeptide agents such as bacitracin and polymyxin B. Details. Now, this is a typical case of a jumping gene. Like this is the details of vancomycin resistance have been documented with the VAN A gene cluster found on a transposon. This is a jumping element on the transposon TN1546 as it's shown on a table over here. So this is the VAN A operon and the VAN B operon. The main element over here is the VAN A gene and the VAN B gene, and the expression depends on what is the genes which are invoked by the other genes that are invoked in this part of the operon. So if you see again, like I told you, the appendix B of M100, which is a mandatory must-know area for all of us, that what are the intrinsic resistances which should be you have to look out for Enterococcus faecalis and Faecium, Enterococcus gallinarum, and Enterococcus cassiliceps. So Faecium, we'll typically see Van A. Faecalis, we might see Van A and Van B both. Enterococcus gallinarum, cassiliceps, we'll see Van C. The resistance mechanisms. So this is one of the slides from a previous presentation. You can again go back on that the mechanism of resistance in gram positives presentation on the IAMM PG channel also. So if we talk about how we are going to detect the vancomycin resistance, so there's a vancomycin screen agar as per CLSI, for which we use the agar dilution method for enterococcus using BHI agar and 6 microgram per ml of vancomycin. And this mechanism, this process has been given in detail in table 3I of CLSI also. So CLSI also mentions the breakpoint MICs and the breakpoint zones for vancomycin and teicoplanin. So for those who cannot or do not have the powder, can always carefully do the MIC by the e-test, or they can do the Covivol distribution also. For Enterococcus, it has been validated. It has not been validated for Staphylococcus aureus because of the heteroresistance issues. So if we talk about the difference between the vancomycin resistance in staph and Enterococcus, so first of all, that vancomycin resistance in Enterococcus is very, very common, whereas it's rare or negligent. Vancomycin resistance staph is rare or negligent. So this might be one of the viva questions to you, that what's the difference between the vancomycin resistance in Staphylococcus and vancomycin resistance in Enterococcus. The resistance in Enterococcus is often transferable through the plasmid, especially in Van A, sometimes in Van B, and it is non-transferable in case of Staphylococcus. The mechanism is the Van A and Van B gene expression creating target site binding changes, as we already mentioned over here. Whereas in case of vancomycin resistant Staphylococcus aureus, now there are two different mechanisms. In case of the Visa isolates, there's normally a thickening, cell wall thickening is there. Whereas in case of the frank VRE isolates, the D-alanine precursor gets hydrolyzed, and therefore the glycopeptide cannot bind to it at all, creating a frank resistance in via of VRSA. MIC creep is not seen for vancomycin in Enterococcus, whereas it might be seen for visa cases or H visa cases, which have to be detected by the population analysis profile studies only. Treatment with vancomycin is not possible in this case because there's frank resistance. It might be possible if the MIC is up to 2 in case of H visa isolates, or maybe almost on the brink of becoming resistant. Might be possible. And in this case, there is no heteroresistance expression is not there. In case of vancomycin VRE, there is no heteroresistance expression, whereas in case of VRSA or VSS visa isolate, there's a heteroresistant expression. So if we talk about the treatment options for the VRE, we are very, very limited. It's quite dangerous actually. So first of all, the treatment will begin with the correct identification of the bug, whether it's faecalis or faecium. So before we go in for treatment, we start the treatment or we give any suggestions. First, we have to correctly identify the bug, whether it's faecalis or faecium. We have to do the proper testing with our KBDD or automation. So we have to have the proper antimicrobial susceptibility testing panels. We have to establish the true pathogenicity of the clinical isolate. Because like I said, it is a common commensal in the stool. It is commonly found everywhere. And even in UTI, you have to be very, very dead sure that it's a true pathogen. Like I said, it does not cause urosepsis. Normally, it will cause COTY. So you have to be very careful how we are diagnosing it. So depending on the syndrome and the site, and it's all about on the case-to-case variation and also on the AST report. The most important thing, like with all infectious disease, is that the reduction of the source. We have to reduce the source. We have to reduce the inoculum. We have to do it by drainage or debridement or to decompress the site of the infection. And normally, in serious cases of VRE, I'm sorry, it's written as CRE infection, but it's actually VRE. The duration of treatment will depend on the severity of the site. Like, for example, bacterial endocarditis because of VRE will be almost 6 to 8 weeks of treatment has to be given. So if you have gone through the tier-based classifications of the antimicrobials for various bugs, you must have seen in table 1D, must have been shown when Dr. Sonal must have introduced you to the CLSI documents, that we got tier 1, 2, 3, and 4 this time. And in tier 1, they have put up ampicillin and penicillin and nitrofurantoin for urine only. So this is the typical distribution of antimicrobials. And as you can see, there's only one page over here. There are not many options that we've got. Vancomycin, gentamicin, vanco in any case is not there. Most of the cases of VRE will be already resistant to gentamicin. They'll be resistant to ampicillins. They'll be resistant to the fluoroquinolones. They'll be resistant to tetracycline also. Most of them. And it's quite a possibility that it might be resistant to linezolid as well. So we are left with very, very few treatment options. Very few treatment options. So this is the tier 1, 2, 3, 4 distribution for enterococcus. And this is the Kabibor ASC panels for enterococcus that we use at IAMS Mangalgiri. So this is the panel of antibodies that we are putting up for the blood and the sterile fluid. So enterococcus isolated, like for example, catalase negative GPCs, which are in chains. So in this case, we are putting up these panels of penicillin, gentamicin, vancomycin, clonophenicol, erythromycin, doxycycline, and if required, linezolid as well. Same similar panel we have got for the pus and the purulent fluids also. And for the urine, the main difference is that we got nitrofurantoin and fosfomycin somewhere over there. Similarly, we have got our enterococcus panel there in the EST 628 for Vitek that we also use. So we are putting up both the KBDDs because some of the antibiotics are not there, like tirecycline. We don't have in there. There are no breakpoint, but still, this particular system it gives you some breakpoints over there. And because some of the antibiotics have to be put up only by the MICs. So if you see daptomycin, it's a good treatment option for VREs, but it's only for enterococcus faecium, and that too it's never to be used for lung infections because it's not effective in lung infections. Now the issue comes at dalbavancin, oritavancin, and telavancin. Now in this case, again, like I said, if you see the previous slide, you'll see they can be tested only by MICs. So we have not been able to put them up in the KBDD panels. They can be tested only by the MICs. And the sad part is that it is to be reported only on vancomycin susceptible enterococcus fecalis isolates. So if we read the CLSF footnotes very, very carefully, we'll see that this is also not a treatment option for VRE isolates. So we are left with linezolid and tedizolid. Now, linezolid is a very good drug, orally available, but for serious infection, we have to go parenteral, 600 mg BD, and it may cause myelosuppression, so we have to be very, very careful. Tirecycline, along with the and quinapristine, dalfapristine, we don't have any breakpoint, but certain commercial systems, they do give breakpoints. I'm not so sure about that. In urinary tract infections, like I said, we have to remove the source of the infections. We have to first remove the catheter because most probable site is that only because they cause COTIs most commonly. We have to have a wait and watch for the resolution of symptoms. You don't it's very easy to start an antimicrobial. It's very difficult to stop it. That's a general dictum for the antimicrobial. So we have to wait and watch for the resolution of symptoms. If the symptoms have resolved, don't have to start antimicrobials because in that case, that's just a colonizer. And if there are systemic or local signs and symptoms persist, then in that case, nitrofurantoin is an excellent drug. We may try Cipro and levofloxacin, fosfomycin only for the enterococcus fecalis and not for enterococcus faecium, and tetracycline as well. So these are treatment options. Now talking about vancomycin-dependent enterococcus. Now what is VDE? Now VDE isolates, they are very rare isolates that grow in the presence of vancomycin. So that might be a question that may be asked to the PG students at what is the vancomycin-dependent enterococcus. And it is usually of the VAN A phenotype in case of enterococcus faecium. So most of the isolates are enterococcus faecium. Even though they are more commonly found in the poultry and the animal isolates of enterococci, but now we have found that they are also seen in enterococcus faecium, in fact, in the humans, and they're isolated from patients on long-term vancomycin therapy, not on teicoplanin. Again, shifting the paradigm to use teicoplanin and not vancomycin. Now, what happens is the DDL gene that encodes for the ligase, actually, that's the one that gets mutated over here, and the DLL ligase at this causes mutation in the DDL, leading to an amino acid substitution resulting in an impaired host DLL ligases. And since only the precursors are terminating in DLL lactate, they are synthesized under the vancomycin inducing condition. So under the presence of vancomycin, only this particular isolate can grow. And we have been fortunate enough to see one of the cases, very rare, it's normally not commonly found. This photograph that you'll see has got two isolates. One isolate is growing near the strip. This is the vancomycin E-test strip, the vancomycin disc, and the teicoplanin disc. So this isolate, so you see this feathery growth that is growing near the disc and the strip. That is one strain. The other strain, which is the blue color, that is growing in the other places. So if you see this feathery growth is not there over here. These are basically two isolated. There are two strains, probably the same patient having a vancomycin dependent enterococcus and a regular vancomycin or a vancomycin susceptible isolate. So what you see over here is feathery growth, and we did the biological and we did the examination. Yes, we did not do the molecular analysis so far, but this isolate was also a vancomycin dependent enterococcus. So that is what we see. You have to be very careful at what you see over here. So the take-home message from today's presentation is that all the postgraduates, they must study and imbibe the basics uh, to establish the true pathogenicity of an isolate with a syndrome is the most difficult part for clinical microbiology. Because I keep on saying again and again that in microbiology, automation is not the same as auto analysis. You get a sample, you have to process it, you have to first understand whether it is a true pathogen or not. The moment you grow something, we immediately report it. That's a typical, you can say you can say typical reflex of every microbiologist. Don't do that. Always correlate with the microscopy. Always correlate with the gram chain finding. Always correlate with the direct appearance of the specimen. And we all have to read good articles from journals like ASM, antimicrobial agents and chemotherapy, JCM, CMR, all these mini reviews. So instead of referring to some local books and all those things, best that we refer to the state-of-the-art journals, documents like the BSET documents. Some of the references I've already mentioned in my presentation. There's a book called as the Coozer's Use of the Antimicrobials. That's also an excellent book. It's already available in most of the groups also. And we have to read all the guidance documents from UCAST and all the CLSI. So, like for example, in our institute, we are having an exhaustive discussion on the CLSI. We've got separate classes for M2, separate class for M7, separate class for M39, and four spread classes, almost like 6 hours, only for discussion on the M100 document. So all these documents with their comments are very, very important, very, very critical. You have to be sure that what are the antibiotics to be given and not to be given, which sample and which patient, which one. With that, again, I'd like to thank IMM for this giving me the opportunity. And as we enter into the first day of the World Antimicrobial Awareness Week, I hope that all of you are celebrating World Antimicrobial Awareness Week at your respective centers. Thank you so much. Take care. Any questions in the chat box? I'd like to answer those. I'll just stop my presentation. If ma'am is there. Any questions from anybody? You can put it in the chat box. I think chat box something is there. Okay, one question is there that good evening, sir. If we are doing exclusive Vitec 2 reporting, P628 card do not have ampicillin but has benzyl penicillin, and as we if penicillin is resistant, we can say it's resistant to ampicillin. Also, P628 gives high level gentamicin synergy resistance. So if we are taking data from this showing only synergistic effect resistance, so we can say HLG is resistant from this. Okay, so it's a pretty long question. I'll have to read again. And forgetting ampicillin. So there are many a times that you will not, for example, penicillin is there, ampicillin is not there. So it can be penicillin resistant, but ampi susceptible. So what we do is we always have a extra panel of antimicrobials which we put up by curve distribution. So please don't throw out KBDD out of the window. It is a very, very good and a very sturdy and a very robust technique and a tried and tested technique. So don't throw it out. So the VAN-C. So VAN-C presentation means it's an intrinsic resistance. It's an intrinsic expression of the resistance that is for the D-ALA and a D-serine. So in that case, Enterococcus gallinatum and Enterococcus fecalis, Enterococcus gallinatum and Enterococcus cassiflavus, you'll see that there's an intrinsic expression of the VAN-C gene that is expressing the D-ALA and D-serine, not D-lactate. So that's why it's a moderate level resistance, and therefore it's causing resistance only to moderate resistance to vancomycin and susceptibility to teicoplanin. So you can post, I think this presentation will be posted by ma'am on YouTube also. So please share these comments on YouTube with your questions. Once it's uploaded, I'll go through those questions and I'll try to answer them at peace. I think ma'am may not be there. So with that, I'd like to end this meeting. Again, wishing all of you a very happy World Antimicrobial Awareness Week. Please try and what we do in our sessions is that there's a snakes and ladders slide that I always put it at the end of my presentation. So while we are taking the attendance for the UGs, we always show that slide for almost 2 minutes. So it's a constant repetition of the good and the bad antimicrobial stewardship practices. So that's one thing that you can also do for the hand hygiene. Also, you can do so. Repetition is more important. With that, I'd like to thank you all for attending this presentation. Thank you.